Hello.
Hello.
Good evening, ma'am.
Good evening. Okay, you can start.
Myself is Dr. Sivangi Dangi, second year resident in Third Surgical Unit 4 under Dr. NMS ma'am. Under Dr. NMS ma'am and Dr. Hiransi Chauhan ma'am. My today's topic is surgical audit on a case of supra-renal mass. My today's topic is surgical audit on a case of suprarenal mass. Clinical presentation and the history. 42 years old female patient having complaint of pain in the right lumbar region since 2 months. Pain is dull aching and non-radiating, associated with headache since 20 to 25 days, and also associated with perspirations since 25 days and the palpitations since 25 days. No history of weight loss. No past history of hypertension and diabetes. No history of fever, burning maturation, and the hematuria. Clinical history and
complaint. What is the main complaint of the patient?
Ma'am, patients complain in pain in the right lumbar region since 2 months and headache, perspirations, and the palpitations since 2 months, ma'am.
Was it a complaint or you take history about this?
Yes, ma'am. She is telling that the sweating and the ghabraman and stuff.
So patient gave history or you took history?
No, ma'am. She is telling.
Okay.
In our ward also, she is complaining of this, ma'am.
Okay.
Then, ma'am, clinical history and the examinations. The pulse rate was 110 beats per minute, which is regular, and blood pressure was on admission is 170 by 100 mmHg. Rest of the general examinations was normal. On
admission, blood pressure was 170 by 100, but after that, for 2 days, how much was the blood pressure?
Ma'am, on the post-op day 2, we will start the AMLO.
We have not operated this patient post-admission.
No. Post-admission, ma'am. Post-admission day 2, when patient's BP is 140 by 90 in the range, ma'am.
And then?
And ma'am, then
130. Fourth day?
On 4th day, ma'am, we have started first post-admission day, we have started AMLO dipping with his it is 130 by 80, ma'am, in ranges. And then we have started Prezocin 5 milligram BD, and on the post-admission day 8, we have started Inderal, ma'am, 20 milligram BD, ma'am. And after this,
initially, how the Prazosin was started and how it was released?
Ma'am, on post-admission day 6, we started Prezocin, which is 5 milligram OBD. Then post-admission day 9, or 8, ma'am. We have started Inderal, 20 milligram BD, ma'am. And with this treatment, the blood pressure is 130 by 80 in range, ma'am.
So only on admission, patient was having
Also,
hypertension.
yes, ma'am.
After that, patient was
No, ma'am.
normotensive.
Yes, ma'am.
Right? It
Yes,
was
ma'am.
only 140/90, not
Yes,
that
ma'am.
much rise.
Yes, ma'am.
Okay.
On a per abdomen examination, approx 6 by 6 centimeter size palpable.
Approximately, don't speak in the short words. Approximately, not
Yes,
approx.
Yes, ma'am. Approximately 6 by 6 centimeter size palpable lump was present in the right lumbar region, which is palpable only by manual examination, ma'am. Having the lump having a smooth surface and firm to hard in consistency with ill-defined margin and does not move with the respiration. On percussion, dull not present over.
It was not moving with the respiration.
No, ma'am.
Okay.
On a percussion, the dull knot was present over the lump in the right lumbar region, and the rest of the abdominal examination was normal, ma'am.
Okay.
Ma'am, my differential diagnosis was a suprarenal mass and the renal mass. In the suprarenal mass may be adrenocortical tumor or the medullary tumor.
But directly adrenocortical tumor and not kidney mass.
Ma'am, there is no complaint of burning maturation, hematuria or fever, ma'am. Renal causes, ma'am.
No, that was not the reason. The patient came with the investigation, and that was the differential diagnosis. Oh, not clinically, patient came with the CT scan.
Yes,
right?
ma'am. Yes,
Okay.
ma'am. Ma'am, the patient is available at the time of the presentation with the CCT abdo-pelvis, which is suggestive of large, well-marginated hypodense cystic lesion with internal hemorrhage fluid. Fluid level suggestive of hemorrhage seen in the right suprarenal region. It shows peripheral hyperdensity within and thick wall along its middle wall. It measures 7 by 6 by 6 centimeter. Right adrenal gland not seen separately, and possibly adrenal mass lesion with the hemorrhage. Multiple.
See, in this, it was written that it is a very large cystic lesion, which is mainly hypoechoic with septa and may have hemorrhage.
Yes, ma'am.
So you don't know what is it, a mass or it is a cystic lesion due to cyst formation due to any other reason, right? Okay.
Yes, ma'am. And also showing the multiple nodular lesion seen in the bilateral visualized lower lobes of the lungs, possibly the metastasis. And mild standing with the thickening of the right paracolic fascia seen. We have done review of CECT abdo-pelvis, which is having the same finding at the outside report, ma'am. This is the CECT abdo-pelvis plate showing the mass in the showing the lesion.
Left is reverse. This is you are showing on the left side.
Ma'am, the plate is it is right side only, ma'am. Ma'am, this is the liver. This is the spleen, ma'am. And this is the showing the lesion over the right suprarenal.
You are showing on the left side. So you have to verify before you start your presentation. You are showing on the left side. This is right-sided mass. Right?
Sorry, ma'am. Yes, ma'am.
So this is a right-sided mass which is compressing over the liver. So you are not sure because the suprarenal is not seen. It is believed that it should be a suprarenal mass, but it may be a liver mass. Liver mass extending lower down. Don't know till you explore the patient. Right?
Yes, sir.
Okay.
Yes, sir. This is the transverse section showing the mass in the right side renal region, ma'am.
So in the second plate, you can see some vascularity is also there on the second plate, right?
Yes, ma'am.
Some vascularity is seen into the cystic lesion. So it is mainly a cystic lesion.
Yes, sir.
Okay. What about kidney? Show, lower down.
Ma'am,
so kidney is pushed down.
Yes, ma'am.
So that is favoring about the suprarenal mass rather than liver mass.
Yes, ma'am.
The kidney is pushed down. Okay.
Yes. Ma'am, for the investigations after presenting with this incidentaloma, Ma'am, first of all, we have to do the 24-hour urinary and catecholamines. And if it is positive, it is means that it is functional tumor. For the functional tumor, we have to do adrenalectomy. And if the reports are negative, then it we will consider the size of the tumor, ma'am. And if the less than 3 centimeter size of the tumor, we have to follow up the patient for the every 6 months with the CT or the MRI, ma'am. And if the tumor size is greater than 5 centimeter, we have to directly go to the adrenalectomy. And if the consider the tumor size is 3 to 5 centimeter, there are the criteria. If the patient is young and there is no risk with patient preference is for the adrenalectomy, then we can do adrenalectomy, ma'am.
So this patient is different from previous patient.
Yes,
that
ma'am.
in this patient they have reported that patient is having mass into the lung also.
Okay, ma'am.
So
Yes,
they consider it as a metastasis from this adrenal gland. If patient
yes,
is having, last time we discussed that if there is a mass arising from the adrenal gland
yes,
and there is a small metastasis in PET scan or the CT scan, then after doing the adrenalectomy, this mass can resolve by itself. It is smaller.
Yes,
Here also they reported there is a small true nodules were reported into the lower part of the lung. So we
yes.
consider it as a metastatic.
Metastasis, ma'am.
Metastasis from adrenal
Adrenal
gland.
gland. Yes, ma'am.
So what was done next?
Ma'am, next we have a
No, what about your metanephrine and all this? Yes.
yes,
Okay.
ma'am. Then we have investigated for the tumor of the adrenal mass. For that, we have for first we have confirmed it is for cortex or the medulla, ma'am. So we have sent the plasma metanephrine level and the 24-hour urinary VMA level, ma'am, which is normal, ma'am. So it is, which means it is not a medullary tumor, and the serum cortisol and the serum DHES level,
Reverse.
which is yes, ma'am. Yes, ma'am.
Reverse. Okay.
Yes, ma'am. It is also
Cortisol.
normal, ma'am.
Hmm.
Yes, ma'am. Ma'am, all the findings are in suggest that the tumor was non-functional. On admission, ma'am, patient BP was 170 by 100 mmHg. Patient's blood pressure is normal with the tablet prazosin and the tablet Inderal. We started tablet amlodipine 5 milligram OD on the post-admission day 2. Then we started tablet prazosin 5 milligram BD on the post-admission day 6 and continued till the patient was admitted. Then we started the tablet Inderal 20 milligram BD on the post-admission day 8. With this treatment, the blood pressure is in the range of the 138 by 80 mmHg, ma'am. This is the figure showing differential diagnosis of adrenal incidentalloma in the patients without the history of the malignant disease. 60% is having the non-functioning adenoma, 10% having the pheochromocytoma, 5% having the cortisol producing adenoma, 1% is aldosteronoma, 5% is the adenocortical carcinoma, 5% is the adrenal cyst, 5% is ganglioneuroma, and 9% is the myelolipoma. Now, what is the next plan? So, can we we should operate or the investigation for the lung metastasis? We have done the CCT thorax for the lung
Because
metastasis.
patient came with the abdomen CSCT, so we planned for the thorax CSCT. Okay.
Which is suggestive of a well-defined heterogeneously enhancing soft tissue density lesion with a spiculated margin in the superior segment of the left lower lung. Findings suggest a primary malignant lung mass. Multiple enlarged lymph nodes are present, suggestive of metastatic mediastinal lymphadenopathy. And a multiple varying size inhomogeneously enhancing soft tissue density nodules in the bilateral lung fields in intrapulmonary and the pleural base locations are present, which is suggestive of the pulmonary metastasis. So the TNM staging is the T4, N3, and MX, ma'am.
So what is the size? Go back. Size of the mass.
Ma'am, size is a 3 by 4 centimeter, ma'am. 3 by 4 centimeter.
So it's a very small mass,
Yes.
not that much large mass, and there were two masses.
Yes, ma'am. Yes.
There were two masses like that. So
Yes,
if it is a metastasis and there are small masses at the lower part of the lung, right?
Yes,
so we should think about it may be a primary also because patient is not male. So
Yes, ma'am.
we do not think about it may be a primary from
Yes.
the lung.
Yes,
We always think about secondary into the lung.
yes, ma'am.
But report suggestive that it is
Primary.
it is homogeneously enhancing lesion, so it should be primary of the lung.
Yes, sir.
So to rule out primary of the lung, which investigations are to be done?
Yes, ma'am. For that, we have done the bronchoscopy. For that, we have done the bronchoalveolar lavage, and the fluid was sent for the cytology, and the biopsy also taken. And the report are the
So
negative.
biopsy was taken. Biopsy was they were not able to see the lump
Lung,
into the bronchoscopy. So
Yes, ma'am.
where at one place they found out there is a narrowing of the bronchi. So
Yes,
they
ma'am.
took biopsy
That's it
from that
there only, ma'am.
because
Yes,
it was peripheral lying lesion. So it has not invaded the bronchi. So they were not able to take the biopsy from the tumor.
yes, ma'am.
So they took it from the narrow part of the bronchi.
Yes,
So that was taken.
yes, ma'am.
Okay.
And
So what was the report of this?
Yes, ma'am. The biopsy report and the pleural fluid cytology was negative for the malignancy, ma'am.
So it was showing only inflammatory.
Inflammatory
It was
cells.
showing inflammatory
Yes.
cells. Okay.
Then, so we have decided to make the CT guided lung biopsy and the FNAC for the confirmation of the malignancy, ma'am. So the FNAC of lower lobe of the left lung suggestive
So
of
CT of the lung was suspicious about this lung malignancy. So it should be ruled out always. Keep in mind, whenever it is a small mass into the lung, which is suspicious about lung malignancy, you should rule out without thinking that. Don't think that it is always a metastasis. Right?
Yes, ma'am. Yes, ma'am. The FNAC of the lower lobe of the left lung suggestive of non-small cell carcinoma of the lung, possibility of the adenocarcinoma, and the biopsy of the lung tissue was suggestive of non-small cell carcinoma, poorly differentiated, ma'am.
Okay.
Next, we have after the non-small cell carcinoma biopsy suggestive of lung biopsy, so we have decided to send the patient to the cancer hospital for the treatment of the lung carcinoma, ma'am.
So, what did you learn from this?
Yes, ma'am. Ma'am, how to rule out the tumor of adrenal mass, ma'am, and with metastasis, ma'am.
So any patient who is having adrenal mass with some nodule into the lung, it is not always, you should directly don't jump for the surgery.
Yes, ma'am.
You have
Yes,
not written that findings that they have written in CCT thorax that there was a multiple lymph nodes in the para-aortic region,
Yes, ma'am.
paracarinal region into the parabronchial region, as well as it was extending into the lymph node of, around the IVC and aorta.
Yes,
that was important. They have missed in CCT of the abdomen that there were lymph nodes into around the IVC and the aorta in previous CCT, which was done outside. So
Yes,
in thorax CCT, they find out there is a lymph nodes also. There was a spread into the lymph nodes also. So that rules out that the patient should not have only a malignancy into the adrenal gland. It should have simultaneously somewhere else.
yes,
Okay. I will talk to Dr. Himanshu. Priya, have you got number? He will join. Priya?
Yes,
Julie?
Ma'am,
yes, ma'am.
Himanshu was supposed to join. Himanshu bhai was supposed to join at 5:30.
But
I think he just joined.
Join.
Okay, he has just joined. Okay.
Okay.
Sorry, I'm sitting outside. I cannot see.
Okay.
The part is shown in the list of participants. His name is showing.
Himanshu bhai?
His audio is not there, ma'am. I'm just looking.
Himanshu bhai?
I think he must. Himanshu bhai?
Yes, Apurva.
Good evening, sir.
Good evening.
Good evening.
Himanshu bhai, good evening.
Neena ma'am.
Good evening, madam.
So we will repeat the history and its findings if you have not
Yes,
seen. Have you seen?
Okay.
Okay, repeat Shivangi. from history.
Like a short case, tell the whole thing.
Okay.
42 years female patient having complaint of pain in the right lumbar region since 2 months. The pain is dull aching and non-radiating, associated with the headache since 20 to 25 days, and also associated with the perspiration since 20 to 25 days and the palpitation since 30 days. No history of weight loss, no past history of hypertension or diabetes, and no history of fever, burning maturations, and the hematuria. The clinical history and the examinations, patient's pulse was 110 beats per minute, which is regular, and the blood pressure was 170 by 100 mmHg at the time of the admission. Rest of the general examination was normal.
Patient when patient got admitted, blood pressure was 170 by 100 on admission, but after that it was 140 by
140 by
90.
90.
You have to say specifically.
Yes, sir.
Okay.
On the per abdomen examinations, approximately 6 by 6 centimeter size palpable lump was present in the right lumbar region by the bimanual examination only, having smooth surface and firm to hard in consistency with ill-defined margin and does not move with the respiration. On the percussions, dull knot was present over the lump in the right lumbar region, and the rest of the abdominal examination was normal. My differential diagnosis was supra-renal mass or the renal mass, and the most likely is the supra-renal mass due to the absence of the hematuria, burning maturation, and a fever.
Show your CCT and this rest of. Okay.
Sir, the patient was available at the time of the presentation with the CCT abdominalis from outside only, which is suggestive of a large, well-marginated, hypodense cystic lesion with internal fluid. Fluid level suggestive of hemorrhage seen in the right suprarenal region. It shows peripheral hyperdensity within and the thick wall along its middle wall. It measures 7 by 6 by 6 centimeter. Right adrenal gland not seen separately, possibly adrenal mass lesion with hemorrhage. Multiple nodular lesions seen in the bilateral visualized lower lobe of the lung, possibility of the metastasis, mild standing with the thickening of the right paracolic fascia seen. Review of the CCT abdominalis was done from our side, which was the same finding as the outside report. This is the CCT abdominalis. Suggestive.
This is reversely capillate. Actually, it is on the right side.
Yes, sir. It is a lesion over the suprarenal region. This is a transverse section showing the lesion in the right lumbar region, and this is the vascularity which is shown in this plate. And this is kidney, which is pushed downward by the mass. For the investigation.
Next slide. Next.
Next, we are confirm the origin of the mass. For that, we have investigated for the plasma metanephrine and the 24-hour urinary VMA, which is normal, which is suggestive of not a medullary tumor, and the serum cortisol and the serum DHES.
It is a non-functioning tumor, not like that non.
Yes, sir, not functioning. No. And the serum cortisol and serum DHES are also normal. All these findings are suggestive that the tumor was non-functional. On admissions, patient VP was 170 by 100 mmHg. Patient's blood pressure is in normal limit with the tablet prazosin 5 mg BD and the tablet Inderal 20 mg BD. We started tablet amlodipine 5 mg OD on the post-admission day 2. Then we started tablet prazosin 5 mg BD on the post-admission day 6 and continued till the patient was admitted. And we started tablet Inderal 20 mg BD on the post-admission day 8. With this treatment, the blood pressure is in the range of the 130 by 80 mmHg.
Next.
What are the next plan? We have investigation for the lung metastasis, for which we have done CCT thorax, which is suggestive of well-defined heterogeneously enhancing soft tissue density lesion with pixelated margin segment of the left lobe lung, finding suggestive primary malignant lung mass. And there is also the multiple enlarged lymph nodes are present, suggestive of the metastatic mediastinal lymphadenopathy. and multiple varying size inhomogeneously enhancing soft tissue density nodules in the bilateral lung fields in the transpulmonary and the pleural base locations, suggestive of the pulmonary metastasis. And the TNM staging is T4N3MX. This is the CACT thorax, showing the lesion in the left lower lobe in the superior region.
They have not written that is a metastasis. In
Yes.
CCT thorax, they write down it is likely to be a small cell tumor,
So, yes, sir.
not metastasis, small cell tumor of the lung. So we
Yes,
think about that we should rule out this malignancy of the lung,
lung.
and so we send patient for the bronchoscopy. Okay, next.
Then patient was sent for the bronchoscopy to rule out whether the malignant lesion present in the lung or not. For that, a bronchoalveolar lavage was done and the sample was sent for the cytology, and the biopsy was taken from the narrowing part of the bronchi, not from the lesion. And the outside of bronchoscopic lung biopsy and the pleural flow cytology was negative for the malignancy. So decision was made to take the CT guided lung biopsy and the FNAC. The FNAC of the lower lobe of the left lung suggestive of non-small cell carcinoma of the lung, possibility of the adenocarcinoma, and the biopsy also suggestive of the non-small cell carcinoma, ovary differentiated. By the biopsy report, we send the patient for the further treatment of lung carcinoma at the cancer hospital.
Himanshu, what will you
Yes, madam.
suggest in this patient?
To me, madam, this is a case of a primary lung cancer and metastasis to the adrenal. That seems more likely.
Yes. So how
Because
should
it's a
we follow
histology
such type of cases? How should we follow?
Oh no, it's very rare case.
Because
But,
adrenal
metastasis-
tumor was very large.
Yeah,
Adrenal tumor was
but-
very large.
but adrenal is very popular site for the metastasis. So many primary tumor get to metastasize in the adrenal. One very important finding, whether to know that the adrenal tumor is primary or metastatic, that is based on CT scan. I think that feature was missing here. If it's a primary adrenal tumor, then there
Okay.
should be some fat content in that tumor.
Okay.
If the density is the more than 10 Hounsfield unit, then usually it is a metastatic tumor rather than a primary adrenal tumor, because adrenal contains fat. So any adrenal tumor will contain that fat, and the density of that fat is nearly 10 Hounsfield unit.
Okay.
If the density is more than 10, say about 30, 40, then it's one of the indication that it is not a primary adrenal tumor and it's a lung tumor. And second most important radiological feature is washout test. If the contrast washing out very fast from the adrenal, again it favors metastasis because the fat will bind that contrast. So if it is a primary adrenal tumor, the contrast will bind in the tumor and the washout test will be negative in that case. So there
So how
these
is it
are very
done?
important CT scan
How is
findings.
it done? Washout test, how is it done?
It's simple. No, it's very simple. It's very simple. Number one, density we can easily measure by Hounsfield.
Okay.
Very simple.
Okay.
Washout means if you give the contrast and you take the film after some time.
Okay.
If it is a fat containing, then it will hold the contrast with them. So if it is a primary adrenal tumor, the contrast washout, the leak will not be rapid. But
Okay,
if
it is
a
also taken up by the
tumor, then contrast
vein
will stop.
also. Okay,
Yeah,
I
because
got the
it
point.
doesn't contain. So that is very important test to differentiate between primary adrenal tumor and metastatic adrenal tumor.
Because we were worried because patient was young. Patient is 48 years old only. And she was not having any other complaint. We noticed hypertension only paroxysmally.
Right.
On admission, it was a high blood pressure, and we consider it as either it may be a renal. Before seeing the CT, we think about renal mass only.
Right.
But when we see the CT, then we find out that it is not a renal mass. It is
Yes, that's true.
adrenal mass.
One very important finding to differentiate between adrenal mass and renal mass on CT scan is that whether it is upper polar renal mass or adrenal mass. One important point is that in case of adrenal mass, the kidney is pushed either above or below or laterally. While if the mass is arising from the upper pole of the kidney, then kidney will usually retain its position. So if kidney is misplaced, it is an adrenal mass. If kidney is remaining there, it is a kidney mass.
So in this patient, we were also thinking about mass arising from the liver also, because it has changed the position and site of the liver. It has pushed the spleen down, but liver shape of the liver is also changed in near the tumor. So we were also thinking about it may be arising from the liver, but
Right.
it was not like that. Okay. So after patient is treated for this mass, should we operate this tumor or not? That is the second question.
See, if it is a lung tumor metastasizing, particularly a non-small cell lung tumor metastasized in the adrenal, and if it is the only metastasis, then adrenal needs to be removed. But if there are other metastases also, then there is no need of surgery.
So after the lung surgery is done, and
it is particularly true for the non-small cell lung tumor which has metastasized to the adrenal, and it is the solitary adrenal metastasis. Then if you remove the adrenal, you can almost cure along with the primary.
okay,
But
in
as
the same sitting, we will not operate in same sitting. We will not operate this patient in same sitting. That is to be a separately operated.
Yeah, it is a separate. Yeah. No, but I think that lungs tumor is also metastasized into the lungs also. That's what I got the information from the city. There is already metastasized, many metastasized, multiple metastases in the lungs, other lungs also.
Yeah, it is a bilateral disease. It is not a single-sided disease.
Yeah, then it is surgery is out of question. I think chemo will help.
They will give radiotherapy in the lung mostly.
Yes.
Yes. So what else you will suggest for other investigation in this patient? Should we do true-cut biopsy or not? Such suspected case, if it is if renal this lung malignancy is not diagnosed, we are thinking about secondary into the lung.
So biopsy of the adrenal tumor?
Yes, because it is a non-operable tumor. Then it is a non-operable tumor.
But nowadays, the indication of biopsy in an adrenal tumor is not so common, because most of the tumor can be diagnosed. But number one, it is whether it is functioning tumor or non-functioning tumor. It is a functioning tumor, then biopsy is out of question. Yes. Secondly, as I said, the radiological finding, that washout test and Hounsfield unit. If it is favors some tumor, then biopsy is not indicated. So biopsy, the indications of biopsy are very rare. So if we need to have some, we are not getting any conclusion out of that metabolic test or a radiological test, then there is an indication of biopsy.
But if this small metastasis, if there is a very small metastasis into the lung and we are not able to do FNSC or true-cut biopsy from the lung, and we are not able to have any tissue diagnosis, like this type of malignancy, should we take? No.
Yes, you can take. If all the radiological finding or metabolic finding doesn't
because
show
GCRI people are not giving any treatment if there is no tissue diagnosis.
Yes, we need to take tissue biopsy. If we are not unable to take biopsy from the lung metastasis, then we can take. But only thing, the absolute contraindication of adrenal biopsies, that pheochromocytoma. So we have to rule out pheochromocytoma. Even all the metabolic tests are negative for pheochromocytoma. There could be a 5 to 10% chances that it could be a pheochromocytoma.
Yes, patient was having hypertension of 170 by 110.
Clinical my diagnosis was that pheochromocytoma.
I was also thinking in the same way. So we stopped the amlodipine and started on prazosin in this patient.
Yeah, that's true.
Yes. So true-cut biopsy is it will be a last resort before giving the treatment. Otherwise, we should not give this. Yes. Any medical treatment for such patient?
Good evening, Himanshu bhai.
Good evening.
Sorry, હું જરા busy હતો. Okay, continue.
So any chemotherapeutic agents specifically?
You asking me, Apurva?
Yes, sir. Yes, sir. Hi, Himanshu bhai.
I just referred this patient to So I don't know.
Oncologist.
I don't know
Yeah,
any
yeah. Okay.
chemotherapy really.
Okay. Ma'am,
Yeah.
Sara, good inputs from Himanshu bhai. Anything else, ma'am?
Himanshu bhai can say anything more for this patient.
No, I don't know about chemotherapy, madam. I don't know. So
Okay,
better
but should we continue with prazosin or not in this patient?
if it is a proven metabolic tumor, then it's all right. Otherwise, no need of getting prazosin. Or at
Okay.
least if you are planning adrenal biopsy, till that time you can continue. But once you finish that adrenal biopsy, then we can discontinue prazosin. We can simply give calcium channel blocker.
Okay.
Is it indicated biopsy?
No. Biopsy is
As
not
a last resort, sir,
the investigation. As a
So
last
I
resort,
asked the
when we are
question that
not
if
able
we
to
are
get
not able to take biopsy from the lung, if it is a very small metastasis or it is a very small tumor into the lung, should we take biopsy or not? For that he was answering that in that case you can take biopsy, but first you think about pheochromocytoma.
So first is metabolic, whether the tumor is metabolically active or not. Number one. Number two, based on the radiological finding, because most of the time a CT scan will give a clear idea whether it is a primary adrenal or a metastatic adrenal. And thirdly, if you take the biopsy from lungs, not possible, then there is a last resort you should take the biopsy, not as a first investigation.
Okay. And when should we plan for adrenalectomy if this tumor is increasing even after giving chemo?
So it's a palliative chemo you are talking about, palliative surgery. If it is causing pain, then we can do palliative. But I don't think the chemo should help.
Will it reduce
After
this
chemo,
adrenal tumor? Will it reduce or not?
yes,
If it is secondary into the
chemotherapy,
adrenal gland.
yes, it will reduce.
Okay.
Because adrenal is a very common site for metastasis. Apart from lung, melanoma, you name the organ, they all can metastasize into the adrenal. It is one of the favorite after say liver and lungs, maybe brain. Adrenal is fourth or fifth more common organ where it tends to get metastasis. Bone tumor, thyroid tumor, malignant melanoma, lymphoma. There are a list of malignancy which tends to metastasize in the adrenal.
But we are not used to of seeing this much large adrenal metastasis. It's from this very small tumor into the lung.
Yeah.
So
metastasis could be larger than the primary. Yes.
Yeah.
If it's a small malignant melanoma, it can metastasize in the adrenal. So it can give a thyroid tumor, can give rise to testicular tumor. So that all can go to adrenal, and that can produce a big metastasis. Then the size of your metastasis is bigger than the primary.
Okay. So this we got newer thing that metastasis is larger than the primary. Adrenal.
Yes, in adrenal it is known, definitely known. It is known thing. But suppose we remove metastasis, is it okay? Vice versa. Can primary be affected or not?
Sir, as I explained, if it is a non-small cell tumor of the lungs, and if it is a only solitary metastasis in the adrenal, then it should be removed.
Yes,
then it
so
will improve the prognosis. But
yes,
in our case,
PET scan will be useful. Himanshu, PET scan.
Sorry.
PET scan.
No, I don't think PET scan will give any more information.
No, the point is that to rule out other metastasis.
CT scan was done for abdomen and thorax, so I think it is covered enough. Okay. So I also believe that we should remove this adrenal. I think in lungs there are multiple metastases. So in that case, we don't get much benefit if it is a multiple metastasis in the lung.
But if it's a solitary, then we can try.
Yes, then we should try. Particularly for the non-small cell carcinoma of the lung, if we remove the adrenal, if it's a solitary, then there are high chances of cure.
Yes, okay. Thank you.
Anything else?
I think we have covered almost everything.
Okay. Thank you, Himanshu bhai.
Thank you, madam.
Thank you, Himanshu.
Thank
Okay.
you.
Thank you, sir.
Thank you, ma'am.